So good evening, everyone. And at the outset, I'd like to thank the organizers for giving me this opportunity to speak here today on disease-specific ventilation in newborn. Some of the things which I'll be discussing in the next few slides have already been spoken in the first lecture, but to complete the discussion, we'll have to go through them. And probably it'll be a recapitulation again. So we know that respiratory distress is the most common indication for NICU admission amongst our neonates, as well as for mechanical ventilation. And also we know that the first line of approach for managing neonatal respiratory distress is non-invasive mechanical ventilation. However, many of these babies who are on an IMV will not be able to sustain their respiration or will not be able to make the gas exchanges with NIV. And nearly 40% of the very low birth weight babies, as well as 80% of extremely preterm babies who are born before 28 weeks of gestational age, ultimately require invasive mode of ventilation at some point of time during their NICU stay. So in today's discussion, we'll shortly discuss regarding the common indications for neonatal ventilation, the goals of neonatal mechanical ventilation when we are planning for ventilating a baby, and what are the factors that needs to be considered while deciding mechanical ventilation for specific diseases, like the modes of ventilation which are available to us, the pathophysiology of the disease, usual settings in different neonatal diseases, and also very shortly regarding the lung protective ventilatory strategy. So what are the common indications for mechanical ventilation in neonates? So it may be a baby who has inadequate or absent respiratory effort while on NIV. So we know that when the patient is on NIV, the patient has to have adequate respiratory effort, but when it is not seen, maybe because of respiratory failure or because of CNS conditions, or when there is a patient with recurrent apnea, or there is failure of NIV, or there is a contraindication for NIV, like in a patient who has cleft palate, or supposing there's a patient who has necrotizing enterocolitis and needs respiratory support, even though it is mild distress, but we would go for mechanical ventilation. Or in a baby who has cardiovascular compromise, a patient who is in shock, needing some respiratory support would eventually should be managed with mechanical ventilation. Or this baby can be a baby who has severe lung disease, or a post-surgical condition like a baby who has been treated for tracheoesophageal fistula, and for tiding over the first 2-3 days, the baby is on mechanical ventilation. So these are some of the common indications for which we might have to ventilate a baby. Now, while we have decided for mechanical ventilation, the goals which we need to keep in our mind is that we need to correct the compromised lung function. We have to ensure adequate gas exchange, that is oxygenation and carbon dioxide removal. We also need to reduce the work of breathing, but while doing so, we have to understand that we should minimize the ventilator-induced lung injury, which Dr. Tapas has already mentioned in his lecture. And we also need to plan extubation as early as we are planning for intubation. So we need actually to individualize this mechanical ventilation based on the pulmonary compliance, airway resistance, because of the disease pathophysiology which is occurring. And thus we have to choose the modality as well as the settings based on the disease context. So a baby who is having respiratory distress syndrome will have certain settings which may not be same for a baby who is having Meconium aspiration syndrome or PPHN, because the pulmonary mechanics as well as the disease pathophysiology will vary. So the factors which needs to be considered while deciding mechanical ventilation are the type of ventilator, whether we have facility for conventional mechanical ventilator, or we also have facility for high frequency ventilation. Then what are the patient triggered modes which are available if we are going for conventional mechanical ventilation. And also we have to think about the pathophysiology of the disease in the beginning of ventilation, as well as the disease progresses or regresses, there will be changes in the pathophysiology which would also affect the pulmonary mechanics, and that needs to be kept in mind while continuing with the ventilation. So the available modes of ventilation has been described extensively in the previous study, but just for recapitulation, we might have availability of conventional mechanical ventilation, which has a facility for pressure limited time cycle ventilation, or there can be availability of volume targeted, or Otherwise, there can be availability of hybrid mode of ventilation. So the pressure-limited ventilation is the most commonly used type of ventilation. And for the last few decades, this had been the most commonly used ventilatory mode in most of the NICUs. And here the gas is driven to achieve peak pressure, and the inflation pressure is set to overcome the airway as well as lung tissue resistance and also the elastic forces, thereby to open the lungs and also to deliver the tidal volume. Here the flow waveform is in a sine wave type, as Dr. Tapas has already shown in very nicely regarding how the flow waveform is formed in the pressure limited ventilator as contrast to the volume targeted ventilator. And here again, it's very important that the operator monitors the change of lung compliance during the course of the disease to avoid under or over ventilation. If we have a facility for volume targeted ventilation, here we set the desired tidal volume. Peak pressure is delivered depending on the compliance or resistance of the lung. Typical tidal volume is 4 to 6 ml per kg. And again, as contrast to the pressure limited waveform where the flow waveform is sine waveform, here it is a square one. And this was also shown in the previous lecture. And there is evidence to show that this type of ventilation decreases the ventilator-induced lung injuries, BPD, IVS, pneumothorax, as well as mortality in preterm compared to pressure-targeted ventilation. Now, the hybrid ones have the combined benefit of delivering desired tidal volume using pressure-limited ventilation, and it also allows for leak correction for inspired air. Ventilation is achieved by breath-to-breath adjustment of pressure based on expired tidal volume of preceding breaths by either increasing or decreasing the PIP to deliver the set volume. So we have already learned that there are many types of hybrid ventilations which are available to us, like the volume guarantee, TTV, PRVC, or the VEPs, depending on the type of ventilator which we are using. So we have to identify what is the conventional mechanical ventilation modes which are available to us and plan our ventilation based on that. We might also have facility for high frequency oscillatory ventilation. Here we know that the tidal volume is less than the dead space, and the knobs which are used for oxygenation, that is the map, is definitely different from that which are used to manipulate the ventilation, that is the amplitude and frequency. So this becomes sometimes easier for managing a patient. And then, however, we have to understand that there is no evidence to say that high frequency oscillatory ventilation is better than the conventional mechanical ventilation for neonatal ventilation. And the studies have shown that there is only a modest decrease in the BPD. They're also inconsistent in most of the studies. So we cannot say that this is a better mode of ventilation as of now. We also try to find out what are the different patient-triggered modes available in our pressure-limited or volume-targeted ventilator. So there can be SIMV, assist control, or PSV. All of these may be present and then available to us. So based on this, we will plan what kind of ventilation we'll be using. Now, before ventilating, we also have to remember certain important points. And this was also told in the previous lecture, that there will be either a flow trigger or a pressure trigger in our ventilator. We have to identify that. We need to set the threshold appropriately and optimally for the weight of the baby. Threshold should be above the artifacts generated by humidity or secretions, etc. But if we see that the patient is having high respiratory rate, we might adjust the trigger sensitivity to a higher level so that there is no repeated triggers. But then again, we have to understand that if we set that threshold higher, there will be increase in the walk-up breathing. So therefore, before increasing the threshold, one needs to rule out auto-triggering due to condensation of moisture in the circuit. Few other things which are important for us to understand is that if we have a pressure induced trigger, then it is usually set at -1 to -2. But if we have a flow trigger, then this setting is not appropriate, and we have to put it at around 2 to 3. So what is the trigger that has to be understood, and the trigger sensitivity needs to be set based on that. Also, as previously it was told that volume triggered targeted ventilation cannot be done with flow sensor, which is at the distal end. So many ventilators like the Servo I has a distal flow sensor, but if we have that, we won't be able to go for volume targeted ventilation. So that needs to be understood, and we need to check where our flow sensor is. Now, the limiting the inflation can be through pressure or volume, and the cycling can be by time and flow. So if we are thinking of keeping a baby on pressure support ventilation, there has to be flow cycling in the ventilator. So that needs to be understood. So in summary, we might have different modes of ventilation like pressure targeted, where we set the peak pressure and the tidal volume varies. And commonly this is used for respiratory distress syndrome, and most of the units have been using this. Then we also have volume targeted ventilation, where we set the tidal volume and pressure varies here. It is appropriate for respiratory distress syndrome or in conditions where surfactant deficiency is there, because also it helps in reducing the ventilator induced lung injuries. We might have availability of hybrid kind of ventilators where we can combine the target volume as well as a tidal volume targeting with the pressure adjustment. And it has been found that this is the most useful method of ventilation for preterm babies with unstable compliance. We might have facility for high frequency ventilator, which would give rapid small volume breaths, but it is usually used in the units as a rescue therapy when the conventional mechanical ventilators are failing. So in severe respiratory distress syndrome, Meconium aspiration syndrome, or air-leak syndromes, we might use high frequency ventilation. But again, one must understand that for neonates who are having mild to moderate degree of respiratory distress syndrome or otherwise respiratory distress, we can or we must go for non-invasive ventilation like CPAP or NIPPV, because these help us in avoiding intubation and preserves the spontaneous effort, as well as mild moderate respiratory distress when managed with such kind of non-invasive ventilation will help us to avoid villi. So now we'll be going to the specific diseases. So first we'll be talking about the respiratory distress syndrome after having understood all the types of ventilators which are available and also the different modalities which we can use, and also regarding the flow sensors or now we'll be discussing regarding certain conditions like respiratory distress syndrome. Now we all know the pathophysiology. As the baby is born prematurely, usually for babies who are less than 27 weeks of gestational age, when the lung formation is not yet completed. So maybe the baby is still in the secular phase. There is structurally immature lung present, as well as there is inadequate surfactant, both of which would lead to atelectasis with ventilation perfusion mismatch, which can lead to hypoxemia as well as hypercarbia. There is respiratory acidosis as well as increased work of breathing due to repeated lot of effort by the baby to expand the atelectatic alveoli at the end of expiration. That would lead to increased work of breathing, which should also contribute to the metabolic acidosis. The respiratory as well as metabolic acidosis would lead to pulmonary vasoconstriction, which can lead to endothelial as well as epithelial cell injury, leading to fibrinous exudates, ultimately leading to hyaline membrane disease. And at the same time, when we are ventilating these babies, there are risks for high FiO2 levels, barotrauma as well as volutrauma, which can lead to inflammatory changes in the lung tissue, release of cytokines. And if the baby is predisposed genetically, there, along with this lung injury, there is a risk for bronchopulmonary dysplasia. If we look at the lung mechanics, the compliance is low, resistance is normal, and hence the time constant would be short. The baby would need a short eye time, and the respiratory rate is high. So there is also associated surfactant deficiency, which is leading to atelectasis. So we need to provide adequate PEEP, and the baby is at risk for hyperoxia when we are ventilating the baby, which can induce bronchopulmonary dysplasia as well as complications like retinopathy or prematurity. High pressures, if given, would lead to intraventricular hemorrhage, barotrauma, as well as volutrauma. But if we go for lower settings, there is also risk for atelectotrauma. So if mild disorders, as you have already mentioned, can be managed with CPAP or non-invasive ventilation, but in severe cases, we'll have to go for mechanical ventilation. And if mechanical ventilation is needed, volume-targeted ventilation is the type of ventilation which is of choice. So here we would set the tidal volume at 4 to 6 ml per kg with a backup rate between 30 to 60 per minute. And the inspiratory time would be a 0.3 to 0.35 second, which is short. And the PEEP needs to be of 5 to 8 centimeter of water, as there is a risk for atelectasis. So the PEEP is maintained a little bit higher. If we give pressure support along with this volume targeted ventilation, then we need to achieve 50 to 75% of the set tidal volume for the SIMV or the backup rates. Some units also use high frequency oscillatory ventilation, more so when the patient is not responding in conventional mechanical ventilation. Here, the frequency would be set at 8 to 12 hertz, MAP of 10 to 16, and the delta P or the amplitude is kept at twice that of MAP. And then it is adjusted to vibrate the chest and the abdomen. IE ratio is kept constantly at 1:2. Where the facilities for volume-targeted ventilation as well as high-frequency oscillatory ventilation is not available, TCPL ventilation can still be used, and the setting is adjusted based on the compliance and the disease evolution. But here again, as Dr. Tapas has mentioned earlier, as the compliance improves, we need to come down on the settings, mainly the PIP, as well as if the baby also has hypocarbia, then we need to come down on the respiratory rate. All this, if not done, then again there can be ventilator-induced lung injuries. So the best method for ventilating at present time these babies who are having respiratory distress in the severe range is volume-targeted ventilation. The general principles which needs to be kept in mind while ventilating babies with respiratory distress syndrome is that we need to give the lowest effective FiO2 to maintain the SpO2 in recommended target range to avoid oxygen toxicity. The PEEP has to be optimal so as to maintain the alveoli in open form, but at the same time to minimize the lung injury. Lung protective strategy has to be there to avoid volutrauma as well as barotrauma by using the lowest pressures and tidal volume necessary, and regular reassessment for adjusting settings as respiratory distress evolves should be done, and especially after surfactant administration. Now, how to wean these babies from ventilator? So the recommended adjustment of volume targeted synchronized intermittent mandatory ventilation is shown here by ventilator parameters. So rate can be reduced till 15 to 20 based on the PCO2 level to maintain it below 50. And tidal volume, however, is not brought down below 4 ml per kg. PEEP again should not be brought down below 5 centimeter of water. I time is usually not touched. It is maintained at 0.3 to 0.35 seconds. And if we are using pressure support along with the SIMV rate, then we might come down on the pressure support. However, once it reaches less than 5, the change to tube compensation should be done. The recommended adjustment for high-frequency oscillatory ventilation by ventilator parameter based on oxygen requirements are again shown in the other chart. So here we can see that the rate is not touched mostly, but we can come down on the map based on the FiO2 level. If we need a FiO2 which is more than 50%, then we can increase the map by 2 to 3. And if the FiO2 is between 30 to 50% requirement, then we increase it by 1 to 2. And if it is less than 25%, then we do not change it. Again, for the CO2, we have to touch on the delta P. And if the CO2 is more than 65, we can increase it by 5 to 10. And if it is between 55 to 65, we increase by 2 to 5. And between 35 to 45, we can reduce it by 2 to 5. And when it is less than 35, we can reduce it by 5 to 10. So volume-targeted ventilation, ability to precisely control tidal volume while minimizing exposure to high or variable pressures makes it more effective and safer for fragile neonatal lungs, and thereby resulting in better short-term as well as long-term outcomes compared to the older methods. It has been proven that it reduces lung injury compared to pressure control ventilation. It improves survival as well as outcomes. And there is also greater stability of gas exchange, automatic self-weaning of pressures, shorter duration of mechanical ventilation, as well as it reduces IVH and mortality. So it has a lot of advantages over the TCPL, which we had been using since a long time. Now, the next condition which we commonly encounter in our neonatal units, which need mechanical ventilation, is Meconium aspiration syndrome. Despite it being a relatively rare, not rare, but it has lower incidence than respiratory distress syndrome, but still 50% of the neonates who have Meconium aspiration syndrome may require ventilatory support. And the pathophysiology, if we look at the pathophysiology, it is multifactorial. Meconium aspiration can lead to mechanical obstruction of the airways, which can lead to air trapping. If there is incomplete obstruction, it can lead to accumulation of air. However, if there is complete obstruction of the airways, then it can lead to atelectasis. There can be chemical inflammation leading to atelectasis, as well as inactivation of the surfactant can also lead to atelectasis, which can lead to intrapulmonary shunting, leading to hypoxia, as well as acidosis, which can lead to pulmonary hypertension. And at the same time, because of the air trapping, there are risks for air leaks. And if we look at the mechanics, the compliance is normal, but resistance is high. Therefore, the time constant is needed longer than that of respiratory distress syndrome. The clinical presentations can be variable based on whether there is complete obstruction or partial obstruction, or whether there is presence of chemical inflammation or surfactant inactivation. So the management also needs to be individualized. Air trapping risk is significant. Therefore, we have to have lower respiratory rate. There is also risk for PPHN. So the PaO2 goal should be between 60 to 80 millimeter mercury, with PaCO2 of 40 to 50 millimeter mercury. That is permissive hypercapnia can also be there, with pH level of 7.3 to 7.4. We need to avoid aggressive hyperventilation. So the suggested initial approach to ventilator support for Meconium aspiration syndrome by ventilatory mode and suspected underlying pathophysiology is shown in this slide. Then we have already understood that there is increase in resistance, increase in time constant with lung hyperexpansion in Meconium aspiration syndrome because of airway obstruction, as well as gas trapping. And because of the alveolar disease, there can be decrease in surfactant function, lung compliance, and ventilation perfusion mismatching, with risk for pulmonary hypertension because of hypoxemia, acidosis, and decrease in nitric oxide synthase. So for conventional ventilation, if we have decided for conventional ventilation for a baby who is having Meconium aspiration syndrome, and we are planning for pressure control ventilation, the PIP should be set in to such level so that there is moving of the chest, and the I time needs to be kept at around 0.4. And the PIP should be adjusted for desired tidal volume. PIP should be maintained at 4 to 6 centimeter water. We do not go beyond 6 centimeter, unlike in respiratory distress syndrome, where we usually go up to 8 centimeter water. The pressure support, if it is continued with a SIMB mode of ventilation, then it should be set at 3 to 4 set of PIP. That means up to 75 to 100% of PIP. If we are planning for volume targeted ventilation, then the tidal volume is kept at around 5 to 6 ml per kg, with limit rate of less than 30, and a PWP is kept at 4 to 6 centimeter water. And similar to that of pressure control ventilation, if we are using pressure support, then the pressure support should be kept at around 75 to 100% of PIP. If high frequency oscillator ventilation is planned, then the Hertz should be kept at 6 to 8, in contrast to respiratory distress syndrome, where we had kept it at 10 to 12. And the delta P should be such that it vibrates the chest and abdomen. And the map should be kept in such a way that the expansion is at 9th rib when we are doing chest X-ray. In the posterior aspect, it should reach by 9th rib. So the next condition which we might encounter in our newborn unit needing ventilation is lung hypoplasia. So the possible etiologies for neonatal lung hypoplasia are shown in this slide. So we can have lung hypoplasia because of oligohydramnios. So in a mother who has prolonged rupture membrane, especially when it had occurred before 24 weeks of gestational age, would have oligohydramnios as well as pulmonary hyperplasia. The fetus would have pulmonary hypoplasia. It can be also associated with conditions like renal dysfunction, like renal agenesis or multicystic or dysplastic kidneys or genitourinary obstruction. It can be associated with thoracic compression, like in diaphragmatic hernia or cystic pulmonary abnormalities, teratoma, large pleural effusions, or it can be associated with certain intra-abdominal conditions like severe hepatomegaly, ascites, polycystic kidneys. Thoracic wall abnormalities can also lead to pulmonary hypoplasia, like in osteogenesis imperfecta or other skeletal dysplasias. Neuromuscular disorders can also be associated, as well as certain abdominal wall defects like omphalocele can be associated with pulmonary hypoplasia. Now, when there is oligohydramnios, there is in the long run, during the fetal period, absence of platelet-derived growth factor A and B, as well as transforming growth factor beta-1, which can lead to decrease in the elastin and collagen formation, leading to defective alveolarization. And at the same time, there is also abnormality in the secretion of vascular endothelial growth factor, which can lead to defective angiogenesis. And both this can lead to increased susceptibility for respiratory disease. And in case of congenital diaphragmatic hernia, there is decreased branching of the bronchioles as well as pulmonary vessels, leading to acinar hypoplasia. The lung, not only on the same side, but also in the contralateral side would be hypoplastic because of this poor acinar development, leading to pulmonary hypoplasia, both on the same side as well as in the contralateral side, which leads to also abnormalities in the formation of the pulmonary vasculature, leading to PPHN. This is again further aggravated by left ventricular underdevelopment as well as right ventricular hypertrophy because of PPHN, resulting in ventricular dysfunction. So when we are planning ventilation, these facts needs to be kept in mind, that these babies are not only having pulmonary hyperplasia, but also having PPHN as well as ventricular dysfunction, both right ventricular as well as left ventricular. So the settings which are suggested for babies who are having lung hypoplasia, including diaphragmatic hernia, can be for synchronized intermittent mandatory ventilation. Like if we are planning for volume targeted ventilation, the tidal volume needs to be kept at 4 to 5 ml per kg with a PIP of less than 20, for a PIP of less than 25 centimeter of water. The PIP is maintained at 4 to 5 centimeter of water. The breath rate is kept high at 40 to 60 breaths per minute with an I time of 0.3, which is shorter than what we had done for Meconium aspiration syndrome. And FiO2 can be started with 40% to maintain a predictal saturation of more than 80%. And in the first hour, we would like to have a saturation of about 92 to 98%, and the overall goal should be more than 90%. The CO2 can be a little bit higher, 45 to 55 millimeter of mercury, but we can also accept something which is less than 65 millimeter mercury. And when we are aiming for the lung expansion in the contralateral lung, it should be up to 9th rib inflation in the chest X-ray in the posterior rib. If we are using high frequency ventilation, the delta P is kept at 24 to 28 with PEEP of 10 to 12, that is the descending pressure at 10 to 12 centimeter of water, and the frequency is maintained at 8 to 10. The rest of the goals are similar to that of synchronized intermittent mandatory ventilation. When we are ventilating for pulmonary hypoplasia, we have to keep in mind certain things. that it requires careful, low pressure, high rate ventilation strategies. Pulmonary hypertension is a major complication, so it needs to be treated with adjunct therapy, and permissive hypercapnia with gentle ventilation is warranted. Next problem which we encounter, which needs ventilation in our unit, is PPHN. It can be associated with meconium aspiration or congenital diaphragmatic hernia with hypoplasia, pulmonary hypoplasia, but it can also be associated with common conditions like pneumonia, respiratory distress syndrome, or even transient tachypnea of newborn. Underinflation and overinflation of lung will lead to increase in the pulmonary vascular resistance that we have understood from our previous lectures. So optimal lung recruitment in this condition would be indicated by 8 to 9 posterior rib expansion on the inspiratory chest X-ray, and this expansion would lead to decrease in the pulmonary vascular resistance. We also need to provide optimal PIP, relatively low PIP or tidal volume, permissive hypercapnia with adequate lung expansion for these babies to avoid barotrauma as well as volutrauma. With severe lung disease, high frequency ventilation can also be used. Another condition which we encounter is apnea, and here usually the lungs are normal. So while ventilating for apnea, we have to keep the PIP at minimum, maybe 12. If we are going for TCPL, the PIP should be maintained at around 4 with a FiO2 of 21%, and rate should be minimum. We can start with 25, but based on the blood gases, we can come down even further to maybe 20. Now, we had been talking about acute conditions which we encounter in our NICU, which needs mechanical ventilation. But bronchopulmonary dysplasia is one condition which is a chronic condition and are little bit different from what we had seen in other conditions. So we might encounter new BPD as well as old BPD in our patients. New BPD is seen in the preterm babies, seen even in preterm babies who may not have undergone ventilation, and this is mostly because of the underdeveloped lungs exposed to the external environment, or maybe because of the ventilation which has been done earlier. In this new BPD, there is decreased alveolarization and surface area, fewer and larger simplified alveoli. There is fibroproliferative changes, but this is rarer than those which is seen in old BPD, where there is diffuse fibroproliferation. And also the epithelial airway lesions are rare as compared to the old BPDs. And there is mild airway smooth muscle thickening in contrast to old BPD, where is marked airway smooth muscle hyperplasia. These babies who are having old BPD had been ventilated with barotrauma and volutrauma. And there are fewer arteries in case of new BPD, which are dysmorphic. But in case of old BPD, the pulmonary arteries show marked remodeling. So there is a difference in the parenchymal changes which occur in new BPD as well as in contrast to the old BPD. Both of them may have mild, moderate, severe, or chronic severe diseases, but old BPDs seem to have more severe or chronic severe diseases. Mild and moderate cases can be managed with NIV, but severe or chronic severe conditions would need mechanical ventilation. Now, while ventilating, we have to understand that bronchopulmonary dysplasia is a heterogeneous disease. So this condition is not only heterogeneous amongst different patients, but is also in a particular patient, there can be heterogeneous kind of lung injuries. So in the first picture, that is in A, we can see widespread atelectatic changes on the right side, whereas there are cystic changes in the left side. In this patient, there are few focal cysts in the parenchyma, but this patient had severe pulmonary hypertension right from birth. Then this other patient, the third patient, has cystic lesions all over both lungs. But this patient, and the D patient, this patient had a strikingly hyperinflated lung with large areas of architectural distortion, narrowing of right and left main stem bronchi, and in autopsy it was found that the alveolus were markedly enlarged and also simplified. So we can see that the disease can be manifesting with different parenchymal changes, and even in the same patient, there can be different parenchymal changes in different areas. So the pathology in bronchopulmonary dysplasia can be not only in the lower airways, but can also be in the upper airways. There can be changes in the glottis, trachea, bronchus, as well as in the bronchioles and distal air spaces. So these all can lead to hypoxemia and hypercarbia. Along with that, there is also high risk of pulmonary hypertension. So while we look at the lung mechanics, we might see that there is normal compliance, but very high resistance, resulting in a need for long time constant, and there is also need for larger tidal volumes. There is also risk for air trapping due to high expiratory resistance as well as bronchoconstriction during expiration. And for avoiding the air trapping, we'll have to go for lower ventilatory rates. And to allow complete exhalation, we also need to have longer respiratory times. So the lower respiratory rates would help in providing not only time for expiration, but also because we have kept the time constant longer, so it will also help in delivery of the tidal volume to the alveoli. Many of these babies, for supporting the spontaneous breaths, we might have to ventilate using different modalities of ventilation like assist control or pressure support. And these would help in decreasing the walk-off breathing. And in conditions where there is severe pneumonia like respiratory syncytial virus infection or other infections, or when there is ARDS-like picture with more restrictive lung disease, a short time constant with higher ventilatory rates might also be needed, or even high-frequency oscillatory ventilation might be needed. Now, while we are ventilating these babies with BPD who are having a chronic lung disease, we not only have to optimize gas exchange, minimize dead space, limit excessive walk-off breathing, and avoid intermittent hypoxemia, which we do for other patients as well, but we also have to support the lung repair, the somatic growth, as well as neurodevelopment. One single framework cannot be broadly applied to all patients, so we'll have to individualize, and whether to titrate on the tidal volume, PIP, rate, or PIP, it should be adjusted on a conventional ventilator based on the careful physical examination and evaluation of available graphic on the ventilator. What we have to keep in mind is that because these babies need ventilation for a long period of time, application of an open lung strategy to optimize distribution of ventilation is a must. So the suggested approaches to mechanical ventilator for infants diagnosed with bronchopulmonary dysplasia based on relative severity of disease is shown here. These charts are taken from the Goldsmith. And we can see that for mild to moderate bronchopulmonary dysplasia, we can keep a tidal volume of 5 to 8 ml per kg. But for those babies who are having chronic severe bronchopulmonary dysplasia, the tidal volume which is needed may be significantly large, almost 6 to 12 ml per kg, because there can be tracheal or bronchial enlargement which might need to be flooded. Thereby, we can reach the alveolus. Before that, we may not, if we are giving small tidal volume, lesser than this, the alveoli may not be reached. Now, if we compare the PIP, which is needed for mild to moderate bronchopulmonary dysplasia, which is around 6 to 8 centimeter of water, and the PIP, which is required for babies who are having chronic pulmonary bronchopulmonary dysplasia, need a much higher PIP, around 8 to 10 centimeter of water to stand the open large airways. The I time is kept as 0.35 to 0.45 seconds in mild to moderate bronchopulmonary dysplasia, which can be as long as 0.5 to 1 seconds. This longer period is needed to overcome the inspiratory airway resistance to enhance volume of delivery to lung units with long time constants. The rate is kept at 20 to 40 breaths per minute based on the effort in mild to moderate bronchopulmonary dysplasia, which can be reduced to 15 to 30 breaths per minute, because they would need adequate expiratory time long enough to exhale with the airways which are also defective. The SpO2 goal is around 92 to 98% for both the conditions, and we also accept permissive hypercapnia for these babies. Now, weaning and extubation also needs to be planned appropriately, cautiously. Weaning from ventilation should be slow and individualized, guided by clinical stability and improvement in lung function. Unlike in other babies where weaning is usually guided by blood gases like PaCO2, here we may not be able to be guided by blood gases, and we'll have to uh, base our weaning on the physical examination, like absence of retraction, tachypnea, recurrent episodes of desaturation. So if these are absent, then we can think about respiratory stability and come down on the pressures, as well as FiO2 slowly. The FiO2 should be brought down to maintain at least a saturation of 92 to 95%, because there is associated pulmonary hypertension. So we do not want to come down too much. And once the baby is stable on a low FiO2, then we can plan for extubation to nasal CPAP or NIPPV. Now, the next problem which we might encounter at times is pulmonary interstitial emphysema. The pathophysiological basis is that it is seen in ventilated preterm babies, usually secondary to rupture of the terminal bronchioles with atelectasis downstream, especially in an homogeneous alveolar lung disease. Usually there is a overdistended lung which tends to rupture. The ventilator setting, if you are using conventional mechanical ventilation, should have a very short I time, low PIP, and small tidal volume. The I time, when it is limited and when it is kept minimal, it may result in redirection of the air away from the overdistended lung areas to other areas with short time constant. So in areas where there is a long time constant, from there, it can go to the areas where there is short time constant with more homogeneous aeration. Expiratory time, as long as possible, should be kept so that it allows reabsorption on the interstitial gas. High frequency ventilation is widely used for this condition. Advantage is that it helps in achieving adequate gas exchange at a lower MEP, limiting damage to the distal airways. And the setting is usually, the frequency is set at 12 to 15 hertz for patients who are at risk for pulmonary interstitial emphysema. But when it has already been established, it is reduced to 5 to 6 hertz. But again, when we are going down on the hertz, we have to see that there will be high tidal volume if the amplitude is not reduced. So that also needs to be maintained. We can also use muscle relaxations, and we can come down on the MEP over 24 to 48 hours. Lastly, very shortly regarding the lung protective ventilatory strategy in all disease conditions. So based on the known risk factors for ventilator-induced lung injury, the basic principles of a lung protective ventilation strategy should be maintained in all kinds of ventilation. So first, we need to avoid delivering high tidal volume, because this can result in overdistension of the alveolus or the sacules, which can lead to volutrauma. And the tidal volume should not exceed in all kind of patients beyond 7 ml per kg. Ideally, it should be kept less, up to 6 ml per kg. Secondly, the atelectasis should be avoided, resolved by recruitment, thereby minimizing the repetitive opening and collapsing of lung units and regional overdistension. So we need to put appropriate PIP for this. Then we need to avoid high FiO2, because this can lead to oxidative stress. And in conditions where there is need for exogenous surfactant, it should be administered not only for respiratory distress syndrome, but also in other conditions like in Meconium aspiration syndrome or in severe pneumonia where there is destruction of surfactant. This, when administered, would help in managing these patients appropriately. So in conclusion, we can say that a good understanding of different types of assisted mechanical ventilator modes with underlying pathophysiology of lung condition to ventilate units for optimal respiratory support. Other